actually, I started in medicine, but switched over to public health as a specialty quite early on, and I've been practicing public health for more than 30 years. So I trained in medicine in Edinburgh, and shortly after graduating, after a few intern type jobs, I came over to Canada, intending to stay for 2 years. I'm still here, but I practiced family medicine in Sydney, Cape Breton, for a little under a year, which was long enough to convince me I would make a really bad family doctor, and also to give me an insight into the relationship of the healthcare system to health outcomes. This was the poorest practice in the poorest town in Canada, and it rapidly became apparent that if I continued to work there for an entire career, absolutely nothing would have changed at the end of that time. I would have dispensed a lot of medications and made absolutely no net difference to the outcomes for those people. That sort of lodged in my brain at the time. I then moved on and did some training in pediatrics in St. John's, Newfoundland, which is where I met my wife, and it was in my future father-in-law's basement that I met my first medical officer of health. I then went to work for the government of Newfoundland, who sent me off to Berkeley to do an MPH, and that's when the light bulb really went on. After that, I was able to complete my fellowship training in community medicine. Sumi asked me to mention mentors along the way. The first mentor would be Dr. Bill Babington, who was the MOH in St. Anthony, Newfoundland, later went to Memorial. And the second one would be Dr. Chan Shah, who's still very active in Ontario, who was then the director of the training program at U of T, and who really was most supportive and helpful. Although I greatly enjoyed living in Newfoundland, the fact was that money was very, very short at that period of time, and it was very difficult. And I thought moving to Ontario would provide more resources to work with to get something done. And also at that time, there was the genesis of the Teaching Health Unit program, and I was always very interested in having one foot in academia and one foot in practice. So opportunity came up in Kingston. And so I moved to Kingston, and where I was for more than 12 years, and it was a terrific experience. When I went there, the health unit was just emerging from a very, very difficult period. I won't go into all of the details, except to mention that the business administrator was in jail at the time. But of course, if I had just stood there, it would have got better, right? Reversion to the mean. But I hope I was able to contribute something at that time. So we developed the Teaching Health Unit. Another mentor that I came across was John Hoey, who was actually my associate, but was somebody with enormous experience in the Quebec system and being responsible for a lot of development in Montreal Health Department. And I learned a great deal from him. In '97, when Richard Chabas stepped down as Chief Medical Officer of Health, I went to the province and took over as Chief Medical Officer of Health. That again was quite a difficult period. That was in the Harris years, at the peak of the downloading, and this was not easy. And in fact, I decided after a little more than a year that I would move on and the federal government had offered me a position in Health Canada, so at that time I moved to Ottawa, and got into something quite different, and it illustrates how you can sort of end up in strange places you never thought you were going to be. Although you may find it hard to believe that there was a time when the internet was brand new and that its application in health was of interest. So at that time, the federal cabinet had given $50 million to Health Canada to explore uses of the internet in health applications. And I took over in charge of surveillance and its use in surveillance. Fascinating, but I will never forget my first day on the job when I met all the people who were already working on this. And in a 2-hour meeting, I had no idea what they were talking about. I heard the most bizarre word. This was beyond IT speak. This was IM speak, and it was. So I went home and said to my wife, "I think I've made the biggest mistake of my career because I have no idea what is going on here." As it turned out, you know, every business has its own jargon, and in fact, it's not that difficult to get a handle on basic concepts in information management, information technology. So we moved on from there. But just to show you how serendipitous these things are, the next interesting thing that happened was, of course, SARS. And it was an outcome of SARS that we had the Naylor Report, and I was seconded to help with the Naylor Report. And of course, working with David Naylor is just a wonderful experience. So Naylor Report came out, and then of course there were enormous opportunities to build up public health infrastructure. Money was flowing, and at that time we were able to do a great deal in national collaborating centers, doubling the size of Field Epi Program, and a lot of work around workforce development. And at that time, you know, it was when, although we weren't directly responsible for it, we certainly helped along the way, development of MPH programs and schools of public health. So I was able to expand the areas of interest from just surveillance to get into knowledge translation and workforce development. And you do have tremendous opportunities at that level, and some of the funding can be quite significant. So during my time with the feds, I certainly was able to travel all over Canada talking to public health people all over Canada, which is a terrific privilege. So eventually I thought I would like to get back into the front line again. There were obviously the glory days of the increased funding were rapidly approaching the end, there was no question about that. So I got an opportunity to move back into frontline public health at the Region of Peel, which is where I am now and have been for getting on for 6 years. That's a very large health department, very active and blessed by tremendous support from all levels of staff, and a very enlightened administration from the CAO and the Commissioner. The downside is that we have the lowest per capita funding of any health department in Ontario, and I have a commitment to repeat that fact every time I speak to anybody in public health in Ontario, and especially to the ministry. So I've discharged that responsibility. So that's a brief run over the career. There's a lot more, and so it does encompass local, provincial, and federal levels, and direct practice of public health, supporting public health infrastructure, and academic activities as well. So we can direct ourselves perhaps to the first slide. I can talk about some of the issues here. This doesn't really need slides, but I thought I'd give you something to look at other than my face. So a little technical issue here, but then we should get going. Okay, and so I wouldn't pay a great deal of attention to how I've split this up. You can look at it anyway. So are there any lessons from my experience? And of course, everybody in public health has a different experience. And mine happens to be as a public health physician. So the lessons I've drawn are, of course, subjective. You might draw different conclusions. And it's you know, more or less generalizable, I think, and I have tried to make it generalizable beyond the role of just a medical officer of health. Yeah, that slide there. And so I'll talk about the three things that have interested me. One is learning, and as you'll see, that's a pretty broad definition of that. Working, where I'm talking about where you're working and what you're doing. So that's about careers. And the third one is leading, which is the leadership issue, which is particular interest for this audience. So just go to the next slide. So you'll eventually see that the first thing I've got written on the learning slide is lifelong, which I don't need to tell this audience about, I'm sure, so that goes without saying. But I have found it's the challenge of learning new things throughout a career that makes the job very satisfying. My second point is mastering the basics. And there, as you know, as public health practitioners, one of our challenges is the incredible breadth of what we do. So the challenge is to know something about emerging issues and all of the determinants of health in which we're engaged, while at the same time maintaining credibility in our core functions and the public health way of doing business. Of course, everybody would have a different definition of what the basic elements of public health are. To me, the job is about making decisions. And therefore, I've always placed a lot of emphasis on using data, and that implies a strong basis in epidemiology, and using evidence. So evidence-informed decision-making. And I think experience has borne out that is a role that public health can play and a contribution we can make that might not otherwise be there. And where we are able to make the important high-level decisions which direct our strategy. So maintaining a mastery of those things is very important. On the other hand, we have these emerging issues. So we can't be an expert in everything. And we should resist the temptation to attempt to do that. We've all heard of health imperialism. But we should be able to talk to people. So it's a matter of understanding. So my experience is that it's a matter of learning a foreign language, whether that be land use planning or social services or health economics or any of the other things which we might get involved in from time to time. To know enough but not to attempt to be the expert, because we can build those relationships with experts that can get the work done. And recognizing that over a career spanning decades, we may move on to other things. So where we were once expert in a certain topic, we no longer are, and that's fine, because we've moved on to something else which is of burning interest at the time. So I want also to emphasize that the broadest definition of learning
it also implies involvement in generating and synthesizing and using knowledge. So we have to do that. Nobody else is going to do that. That's what I've discovered. Very few of us are researchers, but unless we're involved in generating knowledge, our successors will not have available to them the knowledge that they need to make the right decisions to promote the health of the population. So what I've found, and I think one of the messages I want to leave with you is just ask, because I can't recall ever when an academic has said to me, no, I'm not interested, or I'm too busy. So my impression is that academics are in fact very, very eager to get into the world of practice and real decisions. And I think you've all found that there's a growing interest. And so research in public is getting more applied, and a massive growing interest in knowledge translation. Academics can't do this on their own. They must have the practice partners, and that's you and me. I mean, anybody who steps up can do this. You just have to want to do it. And you'll find that people are more than willing to help. And the other thing you can find as a practitioner is that you can get projects going, and you can get funding, and you can get help. So at Peel, we've been able to get quite a few grants, either led by ourselves or more commonly led by other people where we participate, to do things, to find new knowledge or to find ways of applying knowledge. And it's a matter of just chasing down those grants, putting in those proposals, and so on. A perfect example is CHSRF has a program called Executive Training for Research Application, or EXTRA program, which unfortunately is now coming to an end. But over the space of about 4 years, we put 6 people through that program, which is worth about $50,000 a person, just for asking. You know, Public Health Agency of Canada, PHO, other people do have resources that you can tap into if you want to be engaged in that. And then, you know, the publications and the presentations are also very important. So I'll move on to the next one, which is good. Working. So how does one put together a career? Well, the first and most important point is you have to enjoy it, because you're only going around once. So that means finding a passion, finding an organization where their goals and your goals in the longer term are compatible. So your passion within public health may change over time, but there should be something that you're passionately interested in, and you may be more interested in perfecting something that's been around for a long time, or you may be interested in striking out into areas which are completely new where not a lot of people have been before. For example, my interests right now are workforce development and knowledge translation and the built environment. And I knew nothing, essentially, about all 3 of those put together 10 or 15 years ago. In some of them, there's a long way to go. And as you can see, some of these things, like built environment, do crop up, and a lot of people contribute to them, and a lot of people recognize them as being important determinants and want to move that ball down the field. And finding a place, in my own career, I have moved around quite a bit. That is not for everybody, for a variety of reasons. but at a particular time, that place might be different. You might be interested in acquiring different experiences. So I had, for example, over the years a few younger public health physicians come to me, and I have said to them, you know, you've got 30 years, so you don't need to, you know, find the perfect lifetime career right now, because you have time, if circumstances permit, they don't always, to, for example, go to Public Health Agency of Canada, and you might be engaged in international work, or looking at something in very great depth and becoming an expert on a narrow field, or there are lots of other opportunities. So you have to be open to opportunities, which can often come out of the blue. I think my career is like that. Or even within an organization, the changing the jobs, the secondments, the pairing up with researchers, participating in consortia, the online learning opportunities. So there are lots of opportunities for learning and for formal learning, informal learning experience, all of those. And in some cases, you have to make that decision if those opportunities are not there, if I'm not finding my passion right here, and longer term that doesn't look like that's going to happen, then to move on to something else. You know, that old thing about you're either a builder or a maintainer. I'm an extreme example of a builder, and I like to build things, and when they're built, find something else. Not everybody's like that. Okay, the other thing I should mention that we do talk about a bit at Peel is for people who are building a career, the importance of jobs which are technical, scientific in nature, and also the jobs which are management in nature. And for finding senior people, I think a lot of people like me want to look for people who've had both of those experiences. That's the killer combination, is you're an expert in something who can also get the job done. And really, you really have to have both of those kinds of experiences. Okay, how are we doing for time? We're pretty good on time, actually. Right. So the third issue is around leadership. And I wish I could tell you the secrets of leadership. And I wish I could tell you how to learn leadership. I wish I could even tell you that you could learn leadership in the formal learning environment. I really have my doubts about that, actually. That it's completely the case. So obviously, first of all, we all know that we need to distinguish between leadership and management. We all know that having some management capability is necessary, but it's clearly not sufficient in a senior leadership position. And I'm just going to go through a few things there, and you'll see the first one is strategic, and the last one is focus. And both of those are pretty much about the same thing, and a few things in between. Having a sense of strategy, obviously, extremely important. So what is important is it's important to see that. So, for example, when I went to Kingston, where the history is one of, you know, most unfortunate failures in basic management, governance, transparency, and so on, I think it was important that you realized you had to get that right first. That was the most important thing. So I, in fact, there did things like writing a purchasing policy and inventing a performance appraisal system and that kind of thing. because that's where the deficit was, and the message was very clear from both the ministry and the Board of Health is get that right. So what you will find often is you have to earn the credibility to get what you consider important done. But first of all, what's important to others, and make sure you respond to that. With the federal government, none of that was an issue. And very much there the culture was innovation and relationships, working with the provinces. Those were the kinds of drivers there. So you had to have ideas. There's no point in going to the government of Canada and say, I want to fix your basic management stuff, because that's not your job. So you have to respond to what the job is defined as, and you may find later on you're able to push the boundaries and shift what you're able to do. So strategy important, having the vision is important. Delegation and risk. You will find that depending where you are, but generally within the public sector and especially within government per se, there's a risk aversion, a level of risk aversion which is too high. And it's unfortunate you have to continue to work on that. That's why there's so many forms, right? That's why there's so much reporting. That's not the essential business of what you're in. You have to be able to minimize that and move on and get the important things done. It also means that you have to delegate. The larger your organization, the less you can be in control of it. So there's two ways to exert control. One is to attempt to directly exert control. And you can do that by micromanagement, exact over-planning, specifying things, and above all, in having elaborate reporting systems in which you fool yourself that you are actually measuring the activities of your organization. The other way is to have a vision and convey it and develop a culture and develop the skills of people so that they are able to follow that strategy and that vision and accomplish these things on their own. And pretty obvious which one I subscribe to. Another important aspect of leadership, as I see it, and I don't know if you'll see this anywhere else, is what I call reconceptualizing. And that is to be able to say to people, can we look at this another way? And then to be able to develop that message and get people to buy into it. So at Peel, for example, we've come up with some ways of looking at things from a public health way. So I certainly think that it's really important in a workforce where a lot of us come from a clinical background that we're able to look at things through public health eyes, and it's not always the same as the clinical way of looking at the world. And sometimes we don't pay enough attention to that. And for example, to get people to buy into the full scope of what they do, and not, for example, to see their work as delivering services. Our work is not delivering services. Our work is solving problems and achieving our goals. And our goals are about improving health status and reducing disparities. And if every single frontline worker has to understand that and buy into that and not define their job as delivering a program or service. That's an example of reconceptualizing the issues. And then communication, which you can make a case is the single most important skill that you need. You need it because your job if you're a CEO or MOH or director, your job, of course, is to communicate with your governing body, communicate with your outside stakeholders and the public, communicate with other professionals, it's a huge chunk of it is about communication. And you have to be skilled in that. The messages have to be simple and repeated, and you should. One thing I've learned is having a good command of the local data and using local data examples to hammer home a point is very effective in communication. And also part of communication is this idea of, which I'll call developing a persona. As a medical officer of health, who are you? Right? Are you just a technician? Are you a rabid advocate who's always fighting with people? Are you an honest broker? You have to think about things. I won't develop that further, but it is, in my opinion, very useful that you're regarded as an expert, and you are able to use that expertise to persuade people on a course of action without overtly persuading them. The answer will flow automatically from the information you've put before them, and you're not perceived as an advocate or somebody who's trying to be a politician. Then we all know that a leadership job, a lot of it is about managing change. So we glibly say change management, but that's a very inexact science. I would sum it up by the phrase I like is there's two kinds of change: directed change and guided change. And we should be, in my opinion, the guided change approach is the successful way of undertaking change. So building the culture, building coherence about strategic directions, and inviting people to participate first of all, not in carrying out directions, but thinking about what this change is and what it means to them, and then going on from there. So guided change, really important. So to sum that one up, I think the lessons I've learned are avoid micromanagement, don't try and control things, avoid detailed planning, too much emphasis on checking on things and checking on people. More talk and fewer forms is my strategy. And the other one is, of course, to have a strategic plan. Two kinds of strategic plan. One is a document, gets put in a file, and one is a living, breathing strategic plan that you actually guides everything you do. So as you see around the leadership, a lot of it is a matter of where you direct your attention. Overwhelmingly, your attention directed towards the key important things, and minimizing the things which, if not in unguarded moments, can take up a massive amount of your time, but which in retrospect are not so important. So I think I've used up 40 minutes there with assorted pieces of wisdom. So
Great.
I'll hand it back over to Sumi.
Great, thank you, David. Very enlightening and very informative. Now moving on to the second part of this mentoring session, and one of my favorite parts is kind of getting to know our guest speaker a little bit more intimately. I have taken 7 questions from the show that some of you may or may not be familiar with, the Insider Actor Studio, in which they generally ask the guest actor a series of questions. I'm going to ask you a series of questions, and if you can answer them, that would be great, David. So the first question is, what is your favorite word and why?
Well, I think it's Gesundheitsführer. And I like that word because it's a real mouthful. I came across it in a book by Deborah Davis called The Secret History of the War on Cancer, and she was describing actually the Nazi era in Germany, where they had people who were working basically in health promotion, and particularly against tobacco, that they called Gesundheitsführers, and I thought, wouldn't it be nice if we changed the name of Medical Officer Health to Gesundheitsführer? Unfortunate provenance, so I think we'd be unable to do that. Interesting word, though.
Very interesting. All right. So what is your least favorite word then, and why?
Oh, there's so many. Everybody at Peel knows not to say my least favorite words, like align, integrate, framework, blueprint, parameter, lens, silo, all of the jargon. And my least favorite words are not my favorite words because they're imprecise. Nobody knows what you mean by integrate. Really, you know, it's a word you toss in there. Like every plan is an integrated plan. Every strategy is integrated. Come on, let's use some of these words a little more carefully.
All right.
And silo is just done to death. It really is. Let's do something else.
All right, David, thanks for that. That's very interesting, and that must be very hard for you, actually, when you go to meetings, because I'm sure every meeting must have at least one of your least favorite words.
That's true.
All right, so what interests you, or what turns you
on? My interest outside of work is very much history. I'm very fond of history of all kinds.
Okay, so what turns you off, or what doesn't?
What turns me off? Filling out forms turns me off greatly.
All right. What profession other than yours would you like to attempt?
Would like to have attempted, right? Because I don't think I'm going to change now. I really would have liked to have been a landscape gardener.
All right. What profession would you not like to do?
Well, I don't know. Anything that's really boring and doesn't change. So insurance broker, maybe. I mean, I'm sure they do important work. It's just that I'd rather not do it.
All right.
Yeah.
So, if heaven exists, what would you like to hear God say when you arrive at the pearly gates?
Heaven exists. I would say, and it would be St. Peter, not God himself.
Sure.
Him to say, we've reserved you a place in the celestial choir bass section, and the conductors Vivaldi and J.S. Bach on the organ.
Very nice, good company. All right, so that concludes the leaders' questions portion of this mentoring session. We'd like to open up the floor now to the audience, and I wonder, Daniel, who's assisting us right now in the background, can you open up this panel for us so that we might see if there are any questions that are coming in? Any questions so far? So no questions so far. Why don't we give them a few minutes, David? And why don't I ask you a question? So you did speak to, you did offer up kind of some suggestions around around leadership and leadership development and kind of building on that. I wonder if you might offer, as someone who's an employer and also a public health leader, some comments for new professionals and kind of students who are about to graduate, who may frankly have no interest in becoming, assuming say a management position, but but that perhaps doesn't preclude them from wanting to be engaged in leadership related initiatives and activities. What kind of, maybe perhaps some concrete suggestions might you offer them in terms of and nurturing those skill sets? Yeah, well, one of the pleasures of this job is I do supervise people and do resident students. We take quite a few of them at Peel, and people do contact me, and I must say the quality of the people who are interested in public health and are going into public health now is truly outstanding. So I think we've got a bright future given the kind of people who are looking for careers in public health. And you're right, of course, not everybody is interested in leadership or management position. My advice, it's hard to say all of it, but I mean, 2 points that I brought up. One is to get a variety of experience early on, to try a few different things within the field of public health. You often find people coming in with a very specific interest.
very often it's something like global health, and that's terrific. That may not be something they want to be doing for their whole career, but it's a great start. So to try a few different things. I also say to people, you know, get solid base qualifications early on. It's a good feeling to be well qualified and, you know, to have mastered your subject. It's not to say that there are not opportunities later on for, you know, people mid-career to get additional qualifications, but have the opportunity to do it up front. That's often very helpful as well.
Looks like you have a question now.
Okay. Would you like me to read it out?
Yes,
yeah. David, I really liked your comment that having a combo of expertise plus the ability to get it done is a killer combination. How do you build expertise? Can you gain this through on-the-job experience? It just flipped up. Could you bring it back? Okay. Or do you recommend that people pursue higher education, PhD, additional designations, etc., which is something like what I've just been talking about, and I honestly can't say I have an easy answer for that, although I will comment on the issue of a PhD. That's of interest because by and large PhD training is research training. In the States they have a Doctor of Public Health designation, which is something like a PhD with less emphasis on the research and more emphasis on the advanced practice. In the UK you can actually get your, you know, what over here would be your Fellowship of Royal College of Physicians and Surgeons as a non-physician. That's a very high qualification as well, that's open to people from all disciplines. We don't have that in Canada. Nothing to stop people getting qualifications from elsewhere. I have 2 British, 1 American, and 1 Canadian qualification myself. So I think you need a bit of each. Having said that, at a relatively, you know, for the first 2 or 3 steps in your career, what you'll find is that job ads will state a minimum level of formal qualification. So you have to get over that hurdle first. So I would say that today in Ontario, someone looking for a job that's either you know, more of a technical job, the policy analyst, epidemiologist, that kind of job, you pretty well have to have a master's degree. Fortunately, there are a lot more opportunities to get relevant master's degrees, and I mean the MPH type degree rather than MSc now in Ontario. So I'll move on to the next one. I'm a public health specialist having more than 10 years of working experience in both government and non-government organizations back home. Would you please give me some advice regarding my entry into the workforce to the field of public health in Canada? Well, that's a question which I get asked all the time because, of course, in Peel region, half of all the residents were not born in Canada. And furthermore, our immigrant population in, I'm sure applies to all of the GTA, is in fact more highly educated than our native-born population. So we have lots of people who have qualifications from, you know, very often the Indian subcontinent or Africa, who are coming here and want to make use of their qualifications and experience in public health in Canada. So there's no simple one answer to that. I've had many physicians who have, you know, wonderful stories to tell, and many of them have been able to move forward as public health physicians in Canada, and it's really remarkable how committed some of these people are. So there's that one opportunity. A lot of people would have master's degrees. They may have skills in epidemiology or other basic sciences of public health from other countries. The fact is that it depends whether you're a regulated health professional or not. If you're regulated in one of the regulated health professions, medicine, nursing, and dietetics, and so on, then the challenges are much greater, much greater. But you then have an option. Say you were a nurse in another country, there's lots of good work you can do in public health without the designation public health nurse, and your training and experience is relevant. I mean, you might want to go on and, for example, get a master's of public health degree, and then you would be very saleable in public health in Ontario. We have another one. And another question: leadership training and development, what does work? For example, if you have some promising leaders, how do you develop them? Well, that's a pretty challenging question. I don't know I can fully answer it, but I do note that you use two different words. One is training, and the other one is development. The development, I'm a big believer in. The training, formal training in leadership, I don't know. Others might be able to quote some way of getting that kind of training. I'm not sure it's possible. I think it comes through, sure, having some training in relevant topics, but then mainly experience. And that's why I've said it's good to develop both sides, both the technical, professional, public health practice side and the management leadership side, and get experience in both areas. As you know, there are really two schools of thought here. There is a school of thought, and if you go work for the government, you will come across this school of thought. Is there such a thing as generic management, and any person who is skilled in management can manage anything. I emphatically don't believe that. And I think it's one of our strengths in public health that our leadership are public health practitioners. And I think that's of enormous benefit, and long may that continue. So be a good public health practitioner first, and seek opportunities gradually to work your way, both in increasing levels of responsibility and a variety of different types of work. I think in the past we've seen, for example, you're a health inspector, you wait long enough, you get the next step, and then the next step, and so on. I think increasingly we're seeing people who are looking for the edge in getting additional skills. So yes, you must have that base of being a solid practitioner, but that on its own, not enough. Okay. David, do you think there are enough jobs in Canada for the growing number of MPH graduates? Well, good question, one I've heard often before. And in fact, when I was with Public Health Agency of Canada, I would get university professors call me up and say, I'm just putting together my business case for the MPH program, and how many graduates are we short of? And I have to say, I haven't the faintest idea. And then they make reference to the US. Well, the U.S. completely different. 85% of U.S. MPH graduates don't go into public health. They go into managed care. So very different up here. So let me share with you some thoughts, and it's actually my good friend Bren Malufney who did some work for the Federal, Provincial, Territorial Public Health Human Resources Group, which I chaired, that had good insight into this. And what he's saying is there's really three types of MPH grants. There are general programs or specialized programs, and then there are people who go in with a professional designation or public health experience, and those who come right out of their bachelor's degree in an unrelated subject. And what he's saying is, if you go into like an epidemiology stream and get that kind of very specific training, or maybe it's like the public health nutrition stream that they have at U of T, those are very saleable qualifications. If you already have a professional designation, if you are already a public health nurse or a public health inspector, and you are building on that and you want a general MPH, that also is a very saleable combination. Where the problem is people who complete an undergraduate degree in political science or whatever, then go do a general program. They are finding it more difficult to get employment. I believe, yes, there are opportunities and will continue to be opportunities for MPH graduates in our system. And I know that many of the leading health units are employing increasing numbers. We certainly are in Peel. Not only employing increasing numbers, but our existing staff more and more are on a part-time basis gaining that qualification, for example, from Waterloo. Terrific program. So the opportunities are there now, and nobody's pretending for a moment that it's an entry to practice qualification. It's not. There will always be a minority of people in public health who have that qualification, but clearly there are opportunities, and I think increasingly you will see that it's required for leadership positions, certainly manager, director level positions, increasingly required by certainly the larger health departments. Is there any difference between community medicine and public health in Canada? This is about semantics, I think, and not helped by the fact that we keep on changing the name of everything, right? There was a specialty in medical practice recognized by the Royal College and a training program called community medicine. The training program continues and is in fact exactly the same, only the name has changed, and it's changed to public health and preventive medicine. So people like me got to send in their old certificate, get a new one, and they just change the name. That's all that that means. So maybe the question means, is there a difference in practice? Can people with physicians with qualifications in public health and preventive medicine work outside the public health system? And yes, of course they can. Many of them do. Academia, international health, some in primary care settings like community health centers and so on. Okay. Are there any other?
That's it.
That's it, and we've probably run out of time.
Well,
so thank you for the questions. They were, every one of them was an excellent question, I must say.
Well, thank you very much, David, for coming in and being our guest speaker in the second of a 6 series of group mentoring sessions by public health leaders. Really appreciate your time, sharing your journey as well, and sharing your thoughts and suggestions on how we may support career development as well as nurture leadership amongst the public health sector. It was truly and very much appreciated. I hope all of you found this session as interesting as I did. This session will be recorded, so for those of you who wish to kind of go back and listen to David again, you can do that. That will be available on our website, and you'll get an email following that. We also would urge you to complete the online survey, which will be sent to you shortly after as well, and provided with some feedback as we continue to support and improve these sessions. And just want to let you know that our next guest speaker will be Carol Timmings, Chief Nursing Officer over at the Toronto Public Health, and that is scheduled in January. So do take some time and register for that event as well. Thank you very much, David. I hope you found this as enjoyable as we did.
It was most enjoyable. Thank you very much.
Thank you. Thank you all. Have a happy holidays.